Hey everyone, and welcome to this Explainer Masterclass. Look, I know neurosurgery coding can feel like a total maze sometimes, but today we are bringing the energy and breaking it all down. Because let's face it, one slightly wrong measurement or a missed detail about a tissue graft, and boom, you're looking at a major claim denial. So we're going to dive deep into the specific codes for skull defect repairs, cranioplasties, dural reconstructions, and encephalocele repairs. By the end of this, your audits are going to be absolutely bulletproof.
Here's our roadmap for today. We're going to cover neurosurgical anatomy layer by layer, sizing skull defect repairs, the roof leak metaphor, dural repair coding rules, coding encephalocele repairs, and finally, a master audit framework to tie it all together.
All right, let's jump right into Section 1, Neurosurgical Anatomy, layer by layer.
If we want to code these complex cases accurately, we have to think exactly like the surgeon. We have to approach the anatomy layer by layer, working our way from the skin, down to the bone, into the dura, and finally, the brain itself. Reconstructing these layers is absolutely vital. Think about it. After massive events like brain tumor excisions, severe head trauma, deep bone infections like osteomyelitis, or even repairing congenital defects, the skull and those delicate protective layers have to be meticulously rebuilt. You literally have to restore the integrity of the cranial vault to protect the brain.
Now, the very foundation of this anatomy is the skull base, and it's not just some flat floor. The skull base is full of incredibly complex winding passageways distributed across the anterior, middle, and posterior cranial fossae. You've got vital nerves and major blood vessels threading all through these tiny tunnels. So for us coders, knowing whether a surgeon is operating way up at the top of the head or deep down at the complex skull base, that is a massive audit trigger. It fundamentally changes the surgical approach, and more importantly for us, it changes the code.
Moving on to Section 2, sizing skull defect repairs.
When it comes to repairing the actual bone of the skull, your coding relies entirely on precise surgical measurements. The golden rule here, it's the strict 5 centimeter threshold. If you're reading an operative report and that skull defect is exactly 5 centimeters or less in diameter, that's officially a small repair. That triggers CPT code 62140. Surgeons usually fix these smaller holes with bone flaps, tiny plates, or synthetic materials. But the second that defect measures greater than 5 centimeters, boom, we cross over into a large repair. That falls under CPT code 62141, and these massive defects usually require extensive plating, wide mesh, or large customized synthetic implants. But wait, what if the surgeon needs to fix one of those huge defects over 5 centimeters, but instead of using synthetic mesh, they use the patient's own bone? Well, that's your autograft scenario. If the documentation shows the surgeon taking the extra operative time to harvest bone directly from the patient's own split ribs or their iliac crest or a split calvarial graft, that specialized technique triggers its own distinct code. That's CPT 62147. So remember, the actual source of the graft material dictates your code here.
Now, you know as well as I do, sometimes previous surgeries just fail. A patient might come back into the OR with a severely infected bone flap. Maybe the hardware failed, or there's massive cerebral swelling, and that bone just has to come out immediately. If the procedure is strictly the removal of that infected flap or plate, meaning they take it out and leave it out, you're looking at CPT code 62142. However, if the surgeon removes that failed hardware and immediately replaces it with a new graft or plate during that exact same surgical session, then your correct code is CPT 62143.
All right, on to Section 3, and this is a really helpful way to visualize things, the roof leak metaphor.
So, let's go one layer deeper beneath the bone, right down to the dura mater. I want you to picture a house during an absolute downpour. If that roof has a tear in it, water's going to start pouring in, ruining everything inside, right? In neurosurgery, the tough dura mater acts exactly like that waterproof roof for the brain. If the dura tears, say during a really complex skull-base surgery, cerebrospinal fluid, or CSF, starts leaking out. And just like that heavy rainstorm pouring into a living room, a CSF leak is a critical structural failure. The surgeon has to step in, find the exact tear, and create a completely watertight seal to fix it.
Which brings us right to Section 4, dural repair coding rules.
So how do we code sealing up that anatomical roof leak? Well, it depends entirely on the surgical technique and the material used. Here is a massive audit trigger for you. Look at the blood supply. If the surgeon patches the dura using a free tissue graft, like fascia lata, pericranium, or abdominal fat, that material is completely detached. It has zero independent blood supply of its own. That gives us CPT code 61618.
But if the surgeon uses a vascularized pedicle flap, like rotating a temporalis muscle flap into place, while keeping it attached to its original blood vessels, that tissue still has an intact active blood supply. That promotes way better healing, and that specialized technique shifts our code to CPT 61619.
Next up, Section 5, Coding Encephalocele Surgical Repairs.
We have finally reached the deepest layer, the brain tissue itself. First things first, let's get a crystal clear clinical definition. An encephalocele is the actual physical protrusion of brain tissue and meninges out through a defect in the skull. Getting that herniated, incredibly sensitive, and vital brain tissue safely back inside the cranial vault and securing the bone, that is a highly complex, severe surgical procedure.
When you are auditing encephalocele repairs, your final major trigger is location, location, location. If the surgeon is working way up at the upper convexity of the skull, the upper vaults, returning the tissue and doing a cranioplasty, you assign CPT code 6220. But if that protrusion is deep, deep beneath the brain, requiring a complex craniotomy all the way at the base of the skull, that increased surgical difficulty and incredibly delicate anatomical location shifts our code to CPT 6221. So remember, the anatomical zone is everything here.
Let's wrap this all up in Section 6, the Coder's Master Audit Framework.
We have covered a ton of ground today. Let's build a foolproof mental framework so you never miss a beat. Whenever an op report for a neurosurgical reconstruction lands on your desk, I want you to systematically scan for 4 key audit triggers. Number 1, defect measurement. Is it 5 centimeters or less, or is it greater than 5? Number 2, graft source. Are they using a synthetic implant or harvesting an autograft right from the patient? Number 3, blood supply. Is that dural patch a free tissue graft or a vascularized pedicle flap? And number 4, anatomical level. Is the encephalocele repair happening up at the skull vault or deep down at the skull base?
Let's do a rapid-fire mental recap to lock the bone codes in. For skull repairs, always remember the 5-centimeter boundary. CPT 62140 is for your small defects, while 62141 handles the big ones. If the surgeon harvests the patient's own bone for a large defect, you're looking at 62147. And when it comes to hardware complications, strictly taking out a failed plate is 62142. Taking it out and putting a new one in during the exact same session is 62143.
And for those deeper repairs, here's how it shakes out. Continually hunt the documentation for blood supply and anatomical zones. A dural CSF leak patched with a free graft without blood supply is 61618. A vascularized flap with an intact blood supply is 61619. For encephalocele protrusions, an upper skull vault repair is 62120, while a deep skull base repair gets 62121.
At the end of the day, mastering clinical documentation is all about thinking exactly like a surgeon and reading that operative report layer by layer. So, the next time a complex cranial reconstruction crosses your desk, ask yourself, are you just skimming for keywords, or are you truly visualizing the anatomy to ensure absolute accuracy? Keep pushing for that precision, and as always, decode healthcare with Harshal.